Management of hypertension in pregnancy. The clinical emergency. Imagine you're the doctor on duty in the labor room. A 28-year-old woman who is 34 weeks pregnant is rushed in with a severe headache, blurred vision, and swelling of her feet. Her blood pressure is 178 over 116 millimeters of mercury. Urine testing shows significant proteinuria. A few minutes later, she develops a generalized tonic-clonic seizure. Now you have two patients to save, the mother and her unborn baby. Should you immediately start enalapril, one of the most commonly used antihypertensives? Absolutely not. In pregnancy, the drugs that are routinely used outside pregnancy can cause devastating fetal complications, including kidney failure, oligohydramnios, skull defects, and even fetal death. So, which drugs are actually safe? When should you choose methyl-dopa, labetalol, or nifedipine? Why is magnesium sulfate the most important drug in eclampsia, even though it isn't an antihypertensive? In this video, we'll answer all these questions and develop a simple stepwise approach to the pharmacological management of hypertension in pregnancy. Types of hypertensions in pregnancy. The first category is chronic hypertension. This is hypertension that is present before pregnancy or develops before 20 weeks of gestation. Hypertension occurring this early is usually chronic rather than pregnancy-induced. The second category is gestational hypertension. This develops after 20 weeks of pregnancy, but importantly, there is no proteinuria or evidence of end organ damage. These patients require close monitoring because some may later progress to preeclampsia. The third and most serious category is preeclampsia or eclampsia. Here, hypertension is associated with proteinuria, indicating multi-system involvement. When seizures occur, the condition is called eclampsia, making it a life-threatening obstetric emergency requiring immediate treatment. General principles of management. The first principle is fetal safety first. Always choose antihypertensive drugs that have been proven to be safe for both the mother and the fetus. Remember, every drug given to the mother has the potential to affect the developing baby, so safety is the highest priority. The second principle is to avoid sudden blood pressure drop. A rapid fall in blood pressure can reduce uteroplacental perfusion, decreasing blood flow to the placenta, and compromising oxygen and nutrient delivery to the fetus. The third principle is regular monitoring. Management doesn't end with prescribing a drug. The mother should undergo regular blood pressure monitoring, periodic assessment of urine protein to detect progression to preeclampsia, and continuous monitoring of fetal growth and well-being to ensure the fetus is developing normally. Safe antihypertensives in pregnancy. Let's begin with methyl-dopa. It is considered the drug of choice for long-term use because it has the longest safety record in pregnancy. Decades of clinical experience have shown that it is safe for both the mother and the developing fetus, making it an excellent option for chronic blood pressure control throughout pregnancy. The second drug is labetalol. One of its greatest advantages is its versatility. It is available in both oral and intravenous formulations, making it suitable for routine blood pressure control as well as hypertensive emergencies. The third drug is nifedipine, a calcium channel blocker. It is highly effective for oral therapy and is widely used for long-term management of hypertension during pregnancy. In acute situations where intravenous access is not immediately available, immediate release oral nifedipine can also be used to lower severely elevated blood pressure. Drugs for severe hypertension emergency. Now let's discuss the drugs used for severe hypertension, which is an obstetric emergency requiring rapid but controlled reduction of blood pressure. The goal is to prevent maternal complications such as stroke while maintaining adequate placental blood flow to protect the fetus. The first line intravenous agent is IV labetalol. It has a rapid onset of action, produces predictable blood pressure reduction, and is therefore the preferred drug for rapid BP control in most patients. If labetalol is contraindicated, such as in patients with asthma, severe bradycardia, or heart block, IV hydralazine is an excellent alternative. It is an effective arterial vasodilator and has been used safely for many years in obstetric practice. Sometimes, however, intravenous access may not be immediately available. In such situations, immediate release oral nifedipine provides a rapid and effective option for lowering blood pressure until definitive management can be instituted. Drugs to absolutely avoid. Drugs that block the renin-angiotensin-aldosterone system are contraindicated during pregnancy because fetal kidney development depends on this system. Their use has been associated with fetal renal damage, oligohydramnios, skull abnormalities, fetal growth restriction, and even fetal death. Therefore, these drugs should be discontinued as soon as pregnancy is recognized. They include ACE inhibitors such as enalapril, angiotensin receptor blockers or ARBs such as losartan, and direct renin inhibitors such as aliskiren. Management of preeclampsia and eclampsia. Remember, treatment has two major goals: control the blood pressure and prevent or treat seizures. For blood pressure control, the preferred antihypertensive is labetalol, which can be given orally or intravenously depending on the severity of hypertension. If labetalol cannot be used, IV hydralazine is a reliable alternative for rapidly lowering blood pressure. Nifedipine, particularly the immediate release oral formulation, is another effective option, especially when intravenous therapy is unavailable or delayed. The second, and arguably the most important component of management, is seizure prophylaxis. Magnesium sulfate is the drug of choice. Although it is not an antihypertensive, it is the cornerstone of eclampsia management because it prevents recurrent seizures and also treats ongoing seizures. Why magnesium sulfate? At first glance, it may seem surprising that magnesium sulfate is considered the most important drug in eclampsia, even though it is not an antihypertensive. The reason is simple. Seizures, not hypertension itself, are the immediate life-threatening complication of eclampsia. Magnesium sulfate is the drug of choice because it prevents and terminates generalized seizures. It also reduces the risk of recurrent eclamptic fits, making it far more effective than other anticonvulsants in this setting. Another important benefit is its neuroprotective effect for the fetus, particularly in preterm pregnancies, where it reduces the risk of neurological injury. For these reasons, magnesium sulfate has become the standard of care in preeclampsia with severe features and in all patients with eclampsia. Let's conclude with a quick reference summary. For safe antihypertensives in pregnancy, remember the three key drugs: methyldopa, labetalol, and nifedipine. In a severe hypertensive emergency, the preferred agents are IV labetalol, IV hydralazine, and immediate release oral nifedipine when intravenous access is unavailable. For eclampsia seizures, magnesium sulfate is the drug of choice. Remember, it is not an antihypertensive. Its role is to prevent and treat seizures. Equally important is knowing which drugs to never use during pregnancy. These include ACE inhibitors, ARBs, and direct renin inhibitors because of their serious fetal toxicity. Finally, always remember the fundamental principle of management. Prioritize uteroplacental perfusion by avoiding sudden falls in blood pressure. The goal is not only to protect the mother, but also to ensure adequate blood flow to the fetus.